What if a wound isn't just failing to heal, but actively stealing the resources it needs to heal? Every day, a chronic wound can consume or even lose proteins, amino acids, growth factors, immune cells, electrolytes, vitamins, and calories from the body. It's actually quite metabolically expensive having a wound. And what if the wound isn't just failing to heal, but what happens is the body is sending proteins, nutrients to the wound that never seems to stop leaking. And perhaps the important question is, can you actually heal a wound when a patient doesn't have the nutritional resources to rebuild it? And the fact is, a chronic wound can become a significant source of protein loss, aka like a heavily exudating wound. The amount of protein loss through wound fluid can become clinically meaningful, contributing to a cycle of malnutrition, impaired immunity, and delayed healing. So today we're going to explore, when wounds become protein drains pretty much, the proteins that are lost, the exudative tax, may I call it, okay? Because diabetic ulcers can become biochemical vampires, continually demanding resources from the body that are already struggling to provide for them. So, the body was never designed for open wounds. The human body evolved around one major principle: keep the inside on the inside. And blood stays inside the vessels, cells stay inside tissue, proteins stay inside circulation. And when the skin breaks, everything changes. Suddenly, the body is leaking. And imagine poking a hole in a water balloon. Imagine the balloon contains albumin, fibrogen, growth factors, white blood cells, antibodies, electrolytes, and water. And this is exactly what happens inside of a wound. So what is wound exudate? We're all been there. We have heavily exudative wounds. So patients often call it drainage, oozing, leakage, fluid. Clinicians call it exudate. Exudate is not simply water. It's a biologically active fluid containing proteins, cytokines, inflammatory mediators, enzymes, white blood cells, electrolytes, and glucose. Every drop represents resources stolen from the body. So, the history of protein loss research. So, researchers first became interested in protein loss by observing burn patients. As we know, when we have a burn, it oozes fluid. Massive burns created extraordinary fluid loss, and that's a big deal because that's why people have to go to a special burn unit because they actually need fluid resuscitation, and it's actually quite complex. So, patients were literally dying of protein depletion, fluid depletion, and electrolyte loss. And scientists discovered that burn wounds could lose hundreds of grams of proteins daily. And this changed medicine. And for the first time, wounds were viewed as systemic diseases, not just local problems. Wound affects the entire body. So, albumin. Albumin is our first victim. Albumin makes up roughly 60% of our plasma protein. It functions as maintaining the oncotic pressure, it carries hormones, it transports medications, it supports healing. And when albumin fails, edema increases, oxygen delivery worsens, healing slows down. Many clinicians view low albumin as a nutritional problem, but sometimes it often is a wound problem, and the wound is literally draining protein rich fluids. I actually had that myself with a very highly exudative wound with a patient. She was seemed healthy, but when you looked at her labs, the albumin is incredibly low because the wounds were draining so much. And now that she's pretty much almost healed, her albumin levels finally rose up, which is amazing, right? Other things contributed to that as well, but her wounds were a very big source of her protein loss. So let's do the leaky bucket analogy. So imagine trying to fill a bucket. Every day you add water to it, but the bucket has holes. No matter how much water you add to it, it keeps leaking. And that's like a chronic wound patient. You can provide them protein shakes, supplements, and vitamins, but the wound will continue to leak exudative like, and the body struggles to keep up. That's why it is extremely important for us to help heal and close these wounds. Now, the proteins that are being stolen, like we mentioned, albumin, that helps maintain the fluid balance. Immunoglobulins, immunoglobulins, antibodies that are essential for infection control, fibrinogens, critical for clot formation, fibronectin, important for cell migration, growth factors such as PDGF, VEGF, EGF, and TGF beta. The wound loses some of these very molecules needed to heal itself. And it's like it's trying to build a house while someone steals your construction materials. So why are some diabetic wounds even worse? So diabetic foot ulcer, like I said, it always creates a perfect storm. So that's why it can always turn left very quickly, like within less than 24 hours. So with a diabetic patient, we have patients that already have poor nutrition, possibly kidney disease, inflammation, infection, and vascular disease. Now add protein loss, the body becomes and enters into a catabolic state. The muscles break down is accelerated and protein reserves disappear and healing does slow down. So catabolic wounds. So many providers focus on the wound as just a hole. That's why it's not just a hole. Chronic wounds are metabolic diseases. The body responds as if it's under attack. There's even stress hormones that are elevated. Stress hormones rise, such as cortisol, epinephrine, glucagon. And these hormones increase protein breakdown, muscle wasting, and nitrogen losses. And the wound becomes an engine that consuming fuel. Now, another thing that a wound could play a role in is in nitrogen drainage. So, protein contains nitrogen. Nitrogen balance is one of the best indicators of healing capacity. Positive nitrogen balance means that you're building good tissue. Negative nitrogen balance means that you're losing tissue. So, many chronic wounds remain in a negative nitrogen balance for months, meaning that they're losing more tissue than they're creating, and healing becomes nearly impossible. So, wound as a biological vampire. So, the wound is a vampire, in my opinion. It feeds on your protein, energy, blood flow, oxygen, and immune resources. And every day it takes, it takes, it takes. And the larger the wound grows, the hungrier it becomes. That's why I try to tell my patients why some patients need these frequent dressing changes because the wound is quite hungry. It takes, takes, takes. That's why when you see the dressing afterwards, maybe if it's a very heavily exudative wound, you see within like 48 hours, the wound dressing is soaked through, everything is demolished. Even if you put alginate, it's like ate away at the alginate, right? The alginate, some of the alginate remain, but it can eat away at it. So that's the whole point of us having frequent dressing changes, right? We don't want your wound to just be sitting in the wound juice. It can actually break down the wound more. And some wounds become metabolically demanding, and that affects the entire patient. So why does edema get worse when you have a heavily exudative wound? And forgive me for saying, getting tongue-tied with that. But albumin helps keep fluid inside the blood vessels. And when the albumin fails, fluid escapes and delayed swelling develops. And edema increases the tissue pressure and oxygen diffusion decreases and healing slows down. And this creates more inflammation, more exudate, more protein loss, and it creates a vicious cycle. Now, the infection connection. So, infection dramatically increases protein loss. Bacteria triggers cytokine storms, increased permeability, and greater exudative production. So now the wound is leaking even faster. The body responds by consuming even more protein. That's why protein is such a big thing when it comes to wound healing. That's why we actually recommend increasing your protein intake. And that's why nutritionists are such a big role when it comes to us having our wound patients healing. So imagine a healing wound as a bank account. The deposits are we need to deposit protein, calories, vitamins, and blood flow. Withdrawals from the wound will draw through infection, exudate, inflammation, and surgery. And many patients are overdrawn. Their bank account, their wound bank account is overdrawn and it can go bankrupt. So, signs that your patient might be experiencing a protein drain. So, persistent exudate, low albumin, weight loss, muscle wasting, poor granulation, repeated infections, delayed healing, progressive edema, and declining functional status. So, how can we fight back at this protein drains? Okay, we can reduce the exudate by compression when appropriate. If the patient vascular status is not appropriate for compression, you should know better. That's why vascular assessment is a huge thing when it comes to initial assessment and figuring out what's the best dressing for the patient. Sometimes compression is not. Mostly this happens a lot with venous wounds or burn wounds or what they call again, some mixed wounds. But if it's arterial, absolutely not, right? Compression is not the best thing for that. Offloading, we already know that's key. Infection control and moisture balance. Improved nutrition. It is key to have improved nutrition. Protein supplementation, nutrition consult, adequate calories, and micronutrient optimization. Like I said, one of the things I've noticed is patients who are trying to actively get better when it comes to diabetes and control it, they will actually eat less, and that is not the best thing to do. It's not best to eat less. You have to eat healthier, and that's why the nutrition plays a huge role. And your protein intake is a good thing. It's good to eat the proteins, right? That's why I say when you go to your PCP, you should ask for a referral to nutritionist. Especially when you have a new wound, you should have a nutritionist because then they can tell you what are missing, get the right labs. We can figure out what the imbalances are and help you have the right nutrition and supplements that are needed to help you heal because it's not just a wound. The wound is biochemical vampire. Okay. Now, how do we treat the inflammation? We control the infection, we remove necrotic tissue, and we improve perfusion. And how do we heal the wound? One of the best ways is to help close the leakage, right? And that helps by closing the wound. So, in closing, and I guess that's kind of in two ways and more than one, wounds are metabolic diseases. It steals, it drains, it consumes, and every drop of drainage represents a resource that has been used that could have been used to be healed. And the next time you see wound exudate soaking up the dressing, you shouldn't just see fluid. You should see albumin, amino acids, growth factors, immune cells. All of these are leaving the body because the wound doesn't just don't just have damaged tissue. Sometimes they're robbed of every tool that they need to help repair itself. And the hidden story is it could be pretty much like a protein heist. So hopefully people can understand how important it is to assess the exudative amount of wounds and that it's not just a wound being leaky. It actually is a biochemical imbalance that is going on that we actually have to rectify and resolve because sometimes the most dangerous thing in a wound isn't just the tissue, it's the resources needed for the wound to heal. So this was a quick one. This is Diabetics with Files, and I'm Dr. G, and take care of you because they take care of you.